Hello everybody, my name is Terry Duran and I'm a family nurse practitioner. Today we're going to talk about fall risk. Now I know it may not seem like the liveliest subject, however it is something that is very important. So let's get started.
Now, the subject of falls has special significance to me. My mother, who's in her early 70s, fell a few years ago and shattered her hip. Now, she had to have surgery, an extended hospital stay, extended physical therapy, and she was debilitated for about 6 months. Now, luckily, she's doing okay. She has no pain, and her main problem is simply the limited mobility of her right hip, but her outcome could have been very different. Now, let's go over some general facts about falls in adults 65 and over living in the community. It's important to know that falls are the leading cause of death and non-fatal injury in this age group. And the consequences of it result in decreased functional independence, significant disability, and reduced quality of life. 30 million older adults fall each year, resulting in about 30,000 deaths. 1 out of every 5 falls causes a serious injury, such as broken bones or a head injury. And each year, at least 300,000 older people are hospitalized for hip fractures, of which 95% are caused by falling. Now, let's look at falls in the long-term care community. About 5% of U.S. adults aged 65 and older reside in nursing homes, but deaths due to falls by nursing home residents make up 20% of the overall deaths in the same age group. About 35% of injuries due to falls occur in residents who can't walk. The average rate of falls is 2.6 falls per person in any given year, and between 50 and 75% of nursing facility residents fall each year. This is twice the chances of falling if the senior lives in the community. In a typical year, a nursing home with 100 residents reports about 1 to 200 falls, and about 10 to 20% of nursing home falls result in serious injuries. About 1,800 individuals living in nursing facilities die from falls in any given year. That's why this subject is very important. But why are falls more common in these settings? Well, of course, people who are long-term care residents are frailer than senior adults living in the community. They are older, they have problems walking, and suffer from more chronic conditions. Also, LTC residents have an increased rate of memory and thought problems, which means they can't take care of themselves and they need assistance taking care of themselves and getting around. Falls are devastating for residents and their families. They can reduce the quality of life. There can be such a fear of falling in the residents that they don't want it to happen again. So what they do is restrict their activities, which decreases their strength, decreases their balance, and making their risk of falls even greater. There can be decreased ability to function. Maybe before they were ambulating, but now they have to use a walker. Maybe they can't get to the bathroom anymore. There can be serious injuries, which leave people bedridden. And of course, that increases the risk of death. There are also adverse consequences of falls for long-term care facilities themselves. Injuries resulting from falls are a major reason for lawsuits against facilities and staff. This can result in the loss of large sums of money and higher insurance premiums. It creates more work for the staff. There are increased levels of care required for residents who fall. There can be poor ratings, poor internet ratings. While not all falls and injuries can be prevented, this is why it is critical to have a systematic process of assessment, intervention, and monitoring that results in minimizing fall risk. What are the most common causes of falls in the LTC setting? 24% of falls are caused by muscle weakness and gait problems. So this would be the loss of balance and strength that comes along with aging. Also, environmental hazards can cause about 16 to 20% of falls, such as equipment in the hallways. Other contributing factors are poor lighting, wet floors, poorly fitted wheelchairs, and beds that are set too high. A lot of the medications that are anti-anxiety medications or sedatives can increase the risk of falls, particularly those that affect the central nervous system. Difficulty getting from one place to another, such as walking from the chair to the bed. Poor care of the feet and improper use of walking aids like walkers and canes. I do want to mention the use of physical restraints because when I was a nursing assistant in a long-term care facility, we were allowed to use them. But what research shows is that restraints in that setting do not decrease the risk of falls or of injuries related to falls and should not be used as a strategy to reduce falls. In some cases, restraints can actually increase fall risk. Long-term care facilities have a duty to keep senior residents safe. However, we all know there's many challenges in that. Many long-term care facilities have protocols or rules, systems, guidelines that staff must follow to ensure that residents remain safe. And the most effective facilities approach this issue of falling from multiple angles. Now, if we look at this cartoon, you can see that this healthcare worker has come up with a strategy. However, I don't think that it is evidence-based, and the guy does not look very happy about it. But hey, we do need to applaud her efforts. Before we look into the strategies of fall prevention and management, I want to talk about something that is necessary to have within the LTC facilities. And this term is called culture of safety. Now, what it means and what it is used to describe is how the behavior of staff and management affects the safety of residents. The development of a culture of safety is an important first step to ensure that the fall management plan that we're going to talk about later is effective and integrated into the organizational system. Developing a culture of safety requires changes in staff attitudes, beliefs, and behavior, as well as changes in management style. We need to get all the staff to recognize the importance of decreasing fall risk, that they would really see these strategies as a key aspect of protecting the residents and even themselves from serious injury and even death. But this change process requires strong leadership, effective communication, new policy development, and the formation of multidisciplinary teams to address areas for improvement. Empowered staff should also be encouraged to participate in all levels of care. And an environment of no blame, no shame would provide an open atmosphere where staff members can report errors and safety concerns without fear of punishment. For example, if a resident falls, a staff member should not be blamed or shamed. It is unfortunate that it happens, but if the facility has a robust fall prevention and management program in place and the correct documentation has taken place, it can be shown that everything was done to prevent and then respond to that fall. So remember, staff culture of safety equals patient safety. Now let's look at the culture of safety checklist. What needs to be done? What needs to be present to create this culture of safety? Number 1 is strong leadership. Number 2, clearly defined safety policies. Number 3, all staff needs to identify and report safety concerns. Number 4, empowerment of staff to correct safety problems. Number 5, enforcement of safety policies by supervisors and managers. Number 6, regular measurement of staff safety performance. Number 7, analysis and review of procedures. And number 8, safety data and trends provided to all staff. Before we go any further, it is very important that we look at the definition of a fall. Now, the Centers for Medicare and Medicaid Services definition of a reportable fall includes the following: an episode where a resident lost his or her balance and would have fallen were it not for staff intervention, is considered a fall. In other words, an intercepted fall is still a fall. Also, the presence of absent or an injury is not a factor in the definition of a fall. A fall without injury is still a fall. Now, when a resident is found on the floor, the facility is obligated to investigate and try to determine how he or she got there, and to put in place an intervention to prevent this from happening again. Unless there is evidence suggesting otherwise, the most logical conclusion is that a fall has occurred. The distance to the next lower surface, in this case the floor, is also not a factor in determining whether a fall occurred. If a resident rolled or even slipped off a bed or mattress that was close to the floor, this is considered a fall. The Agency for Healthcare Research and Quality has really developed an excellent fall management program. The fall management program is an interdisciplinary quality improvement initiative. It is designed to assist nursing facilities in providing individualized, person-centered care and improving their fall care processes and outcomes through educational and quality improvement tools. They have all kinds of information, and everything that I'm going to talk about from here on out can be found on their website that's listed on the references. Of course, much more. I've taken it and I've condensed it quite a bit. Now, the FNP, which is the Fall Management Program, that's what I will call it from now on, includes two primary approaches to the management of falls and injuries. The first approach is through an immediate response to residents who fall, and the second approach is long-term management. It's very important to have a team to implement the fall management program. So there could be a falls nurse coordinator, a falls nursing assistant, a falls therapist, and these would be the people that respond to falls. So let's look at the fall response. This would be in your long-term care facility, the immediate response, or this first approach of the falls management program, which is the fall response. It is a comprehensive approach that forms the backbone of the falls management program, and it has 8 steps. Now, the first 5 steps are the immediate response that occurs within the first 24 hours after a fall, and steps 6, 7, and 8 are long-term management strategies. This algorithm is very important, and it would be very important to print this out and have it available for staff within the long-term care facility. Let's look at the different steps. So a fall takes place. The first step is to evaluate and monitor the resident. The second is to investigate the circumstances. Number 3 would be to record circumstances, resident outcome, and staff response. Number 4, to fax an alert to the primary care provider. Number 5, immediate intervention. Number 6, falls assessment. Number 7, care plan development. And number 8, monitor implementation and resident response. And you can see the timeline on the other side of the paper, which is very helpful. But let's go into more detail on each one of these steps. So step 1, you come upon a resident in the long-term care facility and they have fallen. Step 1 is to evaluate and monitor the resident for 72 hours after the fall. Immediate evaluation by the nurse after a resident falls should include a review of systems and the description of injuries. Also, the nurse should stabilize the resident and provide immediate treatment if necessary. We need to also look at the resident's condition before, during, or immediately after the fall to investigate possible causes. Risk factors related to medical conditions or medication may be reflected by abnormal values of any of the following. So the vital signs, which includes the temperature, blood pressure, respirations, and pulse. Postural blood pressure is where we check a blood pressure when the patient is lying down, then sitting up, and then standing up. And that is looking for something called orthostatic hypotension, where there's more than a 20 point drop in blood pressure when the person goes from a lying position to a standing position. And that can be a cause of dizziness. and it can be a fall risk for residents. Also, if they're diabetic, or even if they're not diabetic, it would be helpful to maybe check a finger stick blood glucose. Now, when indicated by the resident's condition and history, laboratory tests can be ordered, like a CBC or a urinalysis, checking the oxygen level, electrolytes, and even an EKG. Each shift, the nurse should record in the medical record a review of systems, noting any worsening or improvement of symptoms, as well as the treatment provided, and reference to the fall should be clearly documented in the nurse's note. Step 2 is investigating the fall circumstances. So if the fall circumstances are not investigated at the time of the incident, it is very difficult later to piece together the event and try to determine what actually caused the fall, what were the risk factors. Even when a resident is found on the floor after an unwitnessed fall, direct care staff can use their experience and knowledge of the resident to make educated guesses based on the evidence. What we don't want to see is a response of unknown, and it should rarely be accepted by the nurse manager during the investigation of the fall. Now, if staff fear negative responses from the supervisors, they will not be willing to report near misses or clues that might reflect a staff error. So, as mentioned before, there needs to be a culture of care where there's no blame, no shame. So, nurse managers should be non-blaming and skilled in problem solving with the frontline staff. Step 3 is to record circumstances, resident outcomes, and staff response. A full written description of all external fall circumstances at the time of the incident is critical. So this would include factors that relating to the environment, equipment, and staff activity. Fall circumstances need to include the date, the day of the week, the time, the location, the type of fall, the likely cause, the activity at the time of the fall, the staff that were present, the type of footwear that were being worn, aids in use, side rail use, and if an alarm is being used. Now, again, the referenced website has something called a TRIPS form, and that is a tracking record for improving patient safety. And that is the method that is used in the fall management plan to report all types of falls. So that information is listed right there on the website. The nurse manager working at the time of the fall should complete the TRIPS form. And after talking with the involved direct care staff, the nurse is asked to use his or her experience and knowledge of the resident to piece together clues so that unknown is used sparingly, if at all. But the goal should be not to put unknown on that form. The form should next be checked by the fall nurse coordinator or the director of nursing, and any missing information such as emergency room visits, hospital admissions, x-ray results, or additional medical tests can be added at a later time. Step 4 is to fax the alert to the primary care provider. When a resident falls who has already been entered into the fall management program or the FMP, the nurse should send a fax alert to the primary care provider. And the purpose of this is to inform the physician, the nurse practitioner, or physician's assistant of the resident's most recent fall, as well as the resident's total number of falls during the previous 180 days. Step 5 is to implement immediate intervention within the first 24 hours. An immediate response should help to reduce fall risk until more comprehensive care planning occurs. So this is something that is temporary until the next one, the comprehensive falls assessment, can be completed. But just in the first 24 hours, it is usually clear. So when the fall circumstances and the investigation of the fall circumstances is thorough, it is usually clear what immediate action is necessary. For example, if a resident falls on the way to the bathroom because they just weren't able to get there and they have poor balance, interventions related to toileting and staff assistance would be appropriate. However, if the resident is found on the floor between the bed and the bathroom and staff don't look for clues such as urine or footwear or ask the resident questions, immediate care planning is much more difficult. Now, some examples of immediate interventions are increased toileting with specific frequency of assistance from staff, increased assistance targeted for specific high-risk times, increased monitoring using sensor devices or alarms, increased staff supervision targeting for specific high-risk times, pain management if necessary, protective clothing, so helmets or wrist guards or hip protectors, making sure that the footwear is safe, maybe lowering the bed, specific behavior management strategies. Now, documentation of the immediate response on the medical record is very important. So missing documentation leaves staff open to negative consequences through survey or litigation. So it is very important to document falls and document them in detail. Step 6 is a complete falls assessment. In addition to the clues discovered during immediate resident evaluation and increased monitoring, the FNP Falls Assessment is used for a more in-depth look at the fall risk. And there are 5 areas of risk accepted in the literature as being associated with falls that are included. So the number 1 is medications. We need to look at their medication list and make adjustments if needed. So if there's any antidepressants that could be affecting them. The big thing is antipsychotics. Now, antipsychotics are still used a lot in long-term care facilities, but they have been linked to increased rates of death and really should not be used at all for the elderly. Benzodiazepines are considered sedatives and also should not be used in the elderly. Any other type of sedative or hypnotic and another medication called digoxin. The next area of risk is orthostatic hypotension, which we discussed earlier. And what we're looking for is drops in blood pressure that could cause the person to become dizzy or even pass out. Poor vision is another risk factor. Impaired mobility and unsafe behavior. This would be your dementia patient that is constantly trying to get out of bed that has impaired mobility. The resident's footwear and foot care, as well as environmental and equipment safety concerns, should also be addressed. Step 7 is to develop a plan of care. Results of the falls assessment, along with any orders and recommendations, should be used by the interdisciplinary team to develop a comprehensive falls care plan within 1 to 7 days after the fall. In the fall management program, again, all of this information is available on the referenced website. There is a fall intervention plan, which should be used by the falls nurse coordinator as a worksheet and to record the final interventions selected for the resident. The interventions listed on this form are grouped into the same 5 risk areas used for the fall assessment. Often, the primary care plan does not include enough specific detail to effectively reduce fall risk. Safe footwear is an example of an intervention often found on a care plan, yet to prevent falls, staff must know which of the residents' shoes are safe. This level of detail only comes with frontline staff involvement to individualize the care plan. The fall interventions plan should include this level of detail, and this is where really the fall management team comes into play, making sure that all of this is getting done. Step 8 is to monitor staff compliance and the resident response. While we can develop a plan of care, it is staff compliance that actually reduces the fall risk. So a program success or failure can only be determined if staff actually implement the recommended interventions. Therefore, monitoring staff follow through on the unit is necessary once the care plan has been developed. Resident response must also be monitored to determine if an intervention is successful. Changes in care and alternate interventions should be decided based on continued assessment of the resident, and don't forget about the family input. Now we're going to discuss the long-term management of falls, and this is the second part of the fall management program. All residents in nursing homes have some degree of fall risk. However, the FMP includes various approaches to address different levels of risk. Now, there are 3 classes of residents that should be entered into the fall management program. Number 1, those who fall while in the facility, those with a history of falls, and those who have not fallen but trigger the falls RAP during the minimum data set assessment. And we're going to talk about that in just a little bit when we enter into more detail. Now, if you look at this algorithm, this would be the fall management program progression algorithm. This is discussing long-term management. However, as you can see, as we discuss step 1, you'll notice that there's a bit of overlap with the fall response algorithm, which is okay. Now, let's look at this a minute, and then we'll get into the individual steps. As we look at the algorithm, you will see that these 3 classes of residents are listed on the top. So this would be the fall into the facility, a history of a fall at home, or in another. This would also be upon admission, and if a fall RAPS trigger has been identified. So number 1 would be immediate intervention within 24 hours of a fall or at admission to the long-term care facility. Number 2 is a falls assessment. Number 3 is a falls intervention plan. Number 4 would be the falls intervention monitor. And number 5, 6, and 7 just details how much follow-up a person needs. All right, so let's start with step 1 and let's get into the screening process. And we're going to approach this as if a new resident was admitted to the long-term care facility. The basic criteria for screening are those used in the minimum data set that trigger the falls resident assessment protocol. My husband wasn't born in this country, and when he gets a word wrong in English, or actually if I get a wrong word in Spanish, we need to say that word 5 times to remember it. So I'm thinking here that we can say this 5 times, we can practice it so that we remember what the falls RAP is. So right now I want to invite you to say falls resident assessment protocol, falls RAP 5 times so you can remember what it is. And you might want to remember this for your quiz at the end. So again, falls resident assessment protocol, falls RAP 5 times. Let me give you just a minute to do it. Oh, maybe I'll actually do it. Falls resident assessment protocol, falls RAP. 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 Now, what is this criteria for high-risk residents selection with the MDS? And if you want to do that 5 times with MDS, which means minimum data set, go ahead. All residents with a history of any fall in the last 100 days. So this is the minimum data necessary to identify these high-risk patients. Residents with any of the following risk factors who are judged to be at high risk by the falls team. So if they wander, if they complain of dizziness, if they are on anti-anxiety medicine or antidepressant medicine or antipsychotic medication, Parkinson's disease, dementia, any restraint, or another reason, for example, if somebody has multiple sclerosis and they have unsteady gait, or if they have poor judgment, etc. At that time, the falls team would make a judgment whether to enter somebody into the fall management program. Just to give you a percentage of how many residents you should expect to be in the falls management program, It's estimated that between about 25 to 50% of all residents would be in a falls management program. Step 2 of this is the falls assessment, and this actually comes with a 2-step process. So step 1 of step 2 would be to identify which of the 5 high-risk areas contribute to the resident's fall risk. So the 5 areas are medications, orthostatic hypotension, vision problems, mobility, and unsafe behavior. Step 2, again, of the falls assessment is to send a primary care provider report, receive the order sheet, and make appropriate referrals. Now, once the falls assessment is complete, it should be placed in the resident's medical record. Upon admission, there is also a very simple fall risk assessment tool that can be used. This is called the Get Up and Go test, or you can call it the TUG test for short. This is used to determine safety during rising and ambulation. So the resident should sit in a chair, a normal chair with armrests. You ask them to rise, walk 10 feet, turn around, and walk back to the chair and sit down. The resident should use a cane or a walker if he or she normally does so. And any unsteadiness, loss of balance, or problems with walking should be noted. If we look at the TUG test interpretation, the most important thing that I want you to note is that a score of over 14 seconds automatically indicates that the resident is at high risk of falls and automatically should be entered into the fall management program. In addition, the nurse, again, upon admission, should ask the resident to transfer in and out of bed, on and off the toilet, and in and out of a lounge chair if one is used, and note any difficulty the resident has upon rising, turning, managing clothing, or lowering during the transfers. Step 3 is the falls intervention plan. The care plans that incorporate input from medicine, therapy, and other healthcare professionals are more likely to address the multiple risk factors common in this population. And input from the direct care staff can provide the personal details necessary to target specific behaviors and personal situations of increased risk. So there are 3 aspects to the falls intervention plan, and the first area is interim plan of care for new admissions. Most residents are at higher risk for falling in the first couple weeks following an admission to a LTC facility. However, it may take staff a significant portion of this period to actually develop the comprehensive care plan based on the multidisciplinary approach. So they should have close observation and increased supervision, frequent orientation to their room, bathroom, and facility, especially if they have dementia, medication review, making sure they're using safe footwear, staff assistance to the toilet or bedside commode, use of monitoring or sensor devices, use of pressure, position, seat belt, or other alarm, and if necessary, the use of protective clothing and devices. Note on documentation if a helmet, a wrist guard, or hip protectors are utilized. The second area of focus and continuum of care is the comprehensive care plan development that is driven by the falls assessment. This is where the interventions are individualized. So it's helpful to get input from direct care staff about effective and ineffective strategies that they've tried in the past. Also, input from direct care staff about the residents' individual behaviors and needs. A past fall history, including trips data, which we discussed earlier. Input from the family and the resident. And then, of course, based on this information, the nurse checks those interventions listed in each of the risk categories in the falls assessment that are appropriate. The third area of focus in the continuum of care in the falls intervention plan is intensive care planning for residents with recurrent falls. So often in nursing facilities, there are recurrent fallers, that is, residents who fall 2 or more times. And developing care plans for these residents is especially challenging because they are high fall risk, but also because many staff get discouraged and they think nothing will work. However, careful assessment and care planning can at least reduce the risk of additional falls in most residents. For example, toileting. Often for recurrent fallers, toileting by staff must be individualized and more frequent. Monitoring. Recurrent fallers need more supervision than other residents, either by staff, family, volunteers, or through the use of equipment. Room sensors can be used to detect resident movement, position, or pressure alarms on the bed. A chair or a wheelchair and alarms to prevent unsafe wandering can be helpful. Recurrent fallers should be placed in structured activities and exercise programs whenever possible so that observation by other residents and the activity staff occurs. Bed safety. Residents who try to get out of bed unsafely when alone should be evaluated for a low bed and low floor mat. Full side rails should be used as a means to keep the resident in the bed when they are trying to exit. Trying to climb over the bed rails may result in a serious fall-related injury. Cradled mattresses or perimeters are also useful options. They can have individualized seating. So for residents who exhibit unsafe behavior while in a wheelchair, individualized seating modifications and equipment prescribed by an OT or a PT experienced in functional seating can reduce fall risk. The environment. Staff should work with residents and their families to eliminate all possible hazards in the resident's room and the bathroom. Underlying medical condition needs to be looked at, and every effort should be made to determine what health conditions may be increasing the resident's fall risk. Pain management. Appropriate pain assessment and treatment may reduce unsafe behavior stemming from pain or even discomfort. Protective clothing for residents who are in danger of a head injury. A helmet can provide protection. Wrist guards may be used to protect the resident's wrists and forearms during a fall. Hip protectors should be used for all frail ambulatory residents. And newer brands are easier to use during toileting, and residents should be encouraged to wear them on a daily basis. Also, behavior management. All direct care staff should be skilled in responding to behavioral symptoms in a way to minimize the resident's anxiety and agitation rather than fuel it through inappropriate staff attitudes and responses. Step 4 is a falls intervention monitor. In long-term care facilities, routine supervision of frontline staff may not provide enough consistent information about specific care processes, such as the interventions listed on a resident's fall intervention plan. The reasons for this are many. We all know that in long-term care facilities, there are heavy workloads, there are competing priorities, and there's a lot of staff turnover. As a result, individualized care plans may be implemented inconsistently. That is where your falls team comes in. And as the leader of the fall management program, the falls nurse coordinator uses the fall interventions monitor to evaluate implementation of the program by direct staff care. Step 5, for residents who fall in the facility and those with a history of falls, monitor weekly times 4 weeks, and then every 2 weeks times 4. Step 6, after 3 months with no fall, monitor monthly. Update fall interventions plan as needed. For step 7, for residents who trigger the falls wrap but have not fallen in the past 180 days, this should be reviewed quarterly. When a resident falls, then one must return to step 2 of the FMP progression and revise the falls assessment as needed, and then you can continue with steps 3 and step 4. Now, I do want to say a special word about exercise intervention to reduce fall risk. Really, falls don't need to be inevitable as people get older. And according to the U.S. Prevention Task Force, the strongest evidence indicates that exercise intervention is the best way to prevent falls. All of the other interventions, while helpful in studies, have shown to have small benefit. So, appropriately challenging and progressive strength and balance exercises should be included in a multifactorial falls prevention programs for residents in LTC facilities. There are multiple evidence-based exercise programs aimed at decreasing fall risks that can be utilized in LTC facilities, and the National Council on Aging is the perfect resource to investigate these different exercise programs. So as we look at this cartoon, we have these people that are worried about their grandmother. However, she understands that exercise reduces her fall risk. So in conclusion, fall prevention and management are important and timely issues that need to be addressed in LTC facilities. Applying clinical practice guideline recommendations for fall prevention is very important to the development of a successful fall prevention program. An effective fall prevention and management program can reduce falls and fall-related injuries in the elderly long-term care residents, in turn supporting increased cost effectiveness related to prevention of falls-related injury and mortality. Fewer falls and injury improve caregiver staff job satisfaction and reduce person hours spent on dealing with the medical care required to reduce falls. Finally, facilities that are cited for falls and injury during state inspections are at risk for reduced resident intake and retention and increased family dissatisfaction. Family members and residents really need to know that the facility does everything it can to prevent falls. Then, if a fall occurs, the documentation of the robust fall management program can prove that. So thank you for joining me today. Hopefully I've given you some helpful information in this fall risk webinar.
Thank you for joining me today. I hope that you understand the importance of fall prevention. And now it is time to take your quiz.